Assalamualaikum. Kita mula dengan amal kitab Fatihah. Okay, habis start lah.
Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. My name is Nur Azrin Farhana binti Muhammad Asri, and today I will present regarding the central venous access device, which is focused on PICC or PIC line. Okay, so there are many types of CVADs, which is the central venous access device, and one of them is PIC. PIC or PICC is a peripherally inserted central catheter, and it is a long thin tube that is inserted through a peripheral vein. And pass through to the larger veins near the heart. So the larger veins are the peripheral vein can be in the upper limbs, in the lower limbs, and also on the scalp veins. The common site for insertion is for upper limbs like axillary vein and basilar vein. For lower limbs, usually do at long saphenous veins near the ankle, and also at the scalp we do insert at superficial temporal veins. So the PIC line has, as you can see in this diagram, this is the PIC line, and here is the catheter, and here is the lumen. It consists of the lumen and also consists of the needleless connector here. So sometimes the lumen can be single or triple depending on the usage, and the catheter are placed in the large vein, mainly in this site. So PIC is indicated especially in the long-term inpatient who require long-term intravenous access. For example, like very low birth weight infants, which require continuous parenteral nutrition, or also infants who need life-sustaining medications, and patients who need complex medical disorders, patient who need infusion of fluid, and also in patient with complex medical disorders. It is contraindicated in patient who had active bloodstream infection, patient with a thrombus in the desired vein, and whenever parents do not provide consent, and when vascular access can be achieved with peripheral or midline catheter. So in these circumstances, we should avoid using the PIC line. Okay, on procedure. For procedure preparation, first we need to determine what type of device should we choose. So for neonates, we should choose the smallest diameter and fewer lumen catheter, because we want to reduce risk of thrombus formation, and also to reduce the trauma to patients' veins. Next, we need to determine which vein to select, either in upper limb or lower limb, depending on situation, and we should examine with ultrasound. And next part is to get parental consent, orally or verbally, or written consent, and we should inform regarding the procedure and what are the reasons for insertion and the complications of procedure. And the last preparation is to check for equipments and gather all the supplies. Usually hospital have the PIC insertion kit that are inclusive of everything that needed, and sterility should be maintained also. Okay, so these are the example of PIC line. which is this is the catheter as I mentioned before, and this one had 3 types of lumen, depend on the usage. And this one is the needle needle introducer to introduce the catheter inside the vein. Okay, so firstly for procedure of PIC insertion, uh, first we should mark the insertion site after we do vein selection, and then we should measure the maximum insertion distance. For upper limbs or head, we should measure from the entry point, such as in this diagram, from entry point to the suprasternal notch and to the level of the intercostal space. This measurement is to guide us for the maximum insertion depth. And then for lower limb, we need to check. We need to measure from the entry site of the saphenous vein at the ankle to the along the veins, and then along to the xiphosternum at the level of the diaphragm. This measurement is important so that uh, should we should know the length that we can advance the catheter then. Okay, and then after we do the measurement, we perform proper hand hygiene and wear proper personal equipments and ensure the sterility as well. Clean the insertion site with chlorhexidine or alcohol first, and then create a sterile fill, which is we use the towels or drape, and then flush the lumens of catheter with saline-based solution. This is to check whether the catheter is functioning or not, or whether there is blockage. And then puncture the vein using introducer needle and observe the blood return, such as in this diagram. After that, remove the needle from the introducer and slowly advance the catheter with ease. So after we insert into the vein, we remove the needles out after we check for the blood return, and then you advance the catheter slowly into the veins. And then next is to confirm wire placement in the vein using ultrasound. And if you confirm, then you can remove the introducer in this diagram while holding the catheter with gentle pressure. You may retract and reposition the catheter for central placement, and if there is bleeding, you will need to apply a sterile surgical gauze before applying the sterile dressing. To confirm proper placement as well, we can do chest x-ray after that, and a proper placement of the catheter is in near the SVC or IVC, the superior vena cava and inferior vena cava. And after we have confirmed, we should stabilize the catheter, and closure strips should be applied to the part so that the catheter does not move around. And after doing the after the procedure, we should do a maintenance so that we can uh, we should do proper maintenance after that to prevent from further complications such as infections, bleeding, occlusions, damage to heart, and catheter migration. So maintenance is that we should use a stabilization device. Also important to do frequent flushing of line with saline and heparin to prevent occlusion of blood, and to replace sterile dressings regularly. So these are basically just this is a regular routine that should be done for patient with PIC insertion to prevent this complication. So that's all for the PIC insertion. Is there any question?
case, no question.
Okay, can proceed.
Assalamualaikum. It's the phone call. Okay lah, rasa okay juga. Any questions? So again, where should the tip of PICC lies at? Lies in, sorry. Azrin.
In the whether in the superior vena cava or inferior vena cava.
Ya.
Proper placement.
Mana you dapat that? So kalau dia inferior, contohlah superior vena cava kan.
Yes.
Kalau dekat proximal superior vena cava, is it acceptable? Oh, kalau dekat, because the whole vena cava tu kan, below the diaphragm, everything is actually inferior vena cava. So which part of inferior vena cava yang we want the tip to be lies at? Sorry.
I'm not sure.
Okay, we want it to be at the junction of RA and IVC, or RA and SVC. We don't want it to be in the RA, but we want it to be at the junction, or as proximal as possible to the RA. That's why we call it central. Okay. Okay lah. Boleh move to next one. Keep each presentation for like 10 minutes, and then anything we can discuss after that. Okay. Next.
Okay. So, Assalamualaikum. I hope you can hear my voice clearly and also the presentation. So next we're going to look at Venipuncher, one of the techniques for blood samples. So although most of the laboratory tests are done on blood obtained from heel stick, sometimes larger volumes of blood may be required. So then is when venipuncture are indicated as to obtain larger quantities of blood from infants and also children. And the next one, another indication is that when we want to obtain the blood for culture purposes. The equipments for venipunctures include alcohol pads, tourniquet, 21 or 23 gauge butterfly needle, 3, 5 or 10 milliliters syringe, and lastly evacuated blood tubes. So for venipuncture on infant and children, we may need a butterfly needle rather than the normal syringe and needle, as it is easier to control the position.
Sorry, Shafiq.
Yes?
Sorry to interrupt. I think maybe it's my mistake, but again, this is the same mistake again and again by all the students. I think this is not the routine technique that we use. In fact, it's rarely seen in any of Malaysian punya hospital using Venipuncher tau. It's very rare. I've only used this back in UK. I tak pernah guna pun dekat Malaysia. So ideally, we would like you to present something that is familiar to us, because later on bila you work kan, you won't use Venipuncher in Malaysia. I'm not sure UM used to use it. I think waktu ayah Osman I guna kat UM. Tapi I don't think elsewhere we use it. Now UM pun tak guna pun, it's very expensive. So boleh tak for your presentation we repeat again in next class? Next time. Can we arrange like another session for particularly for presentation, especially Venipuncher lah especially, because the method that we use is different. Okay. So apa yang I nak you buat is try to call our NICU ke atau our general ward, ask the MO there, ask the MO in our pediatric ward, what method do they use for blood puncture, for venipuncture. Or you can ask your seniors because all of your friends, your colleagues who present the procedure to me, I usually ask them to redo, because when this is not the way we do it this is not the way we do it. Okay, there's another method. So I would like you to represent this topic, to present to us and your colleague the method that we are using. You can show us the option these are the option, but the method that we actually use in Malaysia is we use the drop method rather than, especially in pediatric the drop method rather than this is closed method using vacuum. Faham tak? You guys pernah tengok tak orang buat venipuncture dekat pediatric patient dekat Malaysia? Anyone have seen one?
Kat Malaysia tak pernah.
Tak pernah
Kat Malaysia tak pernah.
That's why itu problem dia, because a lot of our reference kita ambil daripada overseas. That's our mistake as well because we don't have the culture of writing and culture of sharing. So end up a lot of this presentation are actually not realistic not realistic. So can we arrange another session? You redo this presentation and then we spend like 10-20 minutes just for venipuncture, because this is very important for later
Boleh.
Okay. So proceed with next one.
Okay. Okay, Assalamualaikum warahmatullahi wabarakatuh. Can you see my slide? Wait.
Yes.
Okay, Assalamualaikum warahmatullahi wabarakatuh. So now I'll continue with the nasogastric intubation. I am Nik Kamila Iman binti Ni Abdullah. So nasogastric tube is a tube that is passed into the stomach via the nose to meet patient as a mean to meet patient hydration and enteral nutritional support for decompression of the GI tract, delivery of medication, drainage of stomach content, assessment and treatment of upper GI bleed, and also to diagnose disease, especially in neonates. However, there are several contraindications, such as upper GI stricture obstruction, or if there is fractures to the base of the skull, if there is nasal, maxillary, oropharyngeal, or esophageal trauma, because it could worsen the trauma, if there is a recent esophageal or gastric surgery, and low platelets or clotting disorders, because it could cause bleeding. So patients with these conditions are contraindicated for this procedure. And then for the equipments needed for this procedure for nasogastric intubation is the NG tube, nasogastric tube, sizes ranging from 8 to 12 French. The size of the tube, it varies depending on the patient's age. And then we also need a syringe. For neonates, we can use the 5cc syringe, whereas for older children, we use the 20cc syringe. And then we need water-based lubricant, stethoscope, sterile water, and lastly tape. Okay, and then moving on to the procedure. So first, we need to position the patient in for infants. We need to position the infant in a supine slide head up position, whereas for a child should be in a comfortable sitting position, held by the guardian or healthcare provider. And then secondly, we need to estimate the length of the nasogastric tube inserted. So we can do this by measuring the tube from the bridge of the nose towards the earlobe and then down to the point between the lower tip of the sternum and also the umbilicus. And then we mark the point with a tape or a marker to ease the insertion process. And then the third step is we lubricate the tip with a water-based lubricant, and then we can start inserting the tube gently into the nose. So keep inserting until the mark is at the edge. The mark that we taped earlier is at the edge of the nostril. So if the patient starts to gags or cough, gags or chokes or cough excessively or even become paler or cyanotic, then we should remove the nasogastric tube immediately because it may indicate that the tube is inside the trachea. So remove the tube and then let the patient rest and recover first before trying again. And then next, confirm the placement of the tube by aspirating a small amount of stomach contents using the syringe and using the syringe. So next we can we need to recheck the placement by plunging air into the stomach while listening with a stethoscope, or we can check the acidity of the stomach content using a pH strip. After confirming the placement of the tube, secure the nasogastric tube to the protective skin base with a tape, and lastly, carefully remove the guide wire if the tube has a guide wire. The complications there are several possible complications following this procedure, such as the discomfort, especially at the nasal area, and then epistaxis, and trauma to the upper GI tract can also occur, but this can be prevented if by generously lubricating the tube tip or by and also by doing a gentle technique. Other complications that can occur are aspiration of the stomach contents into the respiratory tract and also pulmonary intubation. So that's all about the nasogastric intubation.
Okay, good. Any questions? Oh, yes. Any questions, guys? No questions. Okay, good. Can proceed with the next one. Oh, I've got one question.
Oh. Okay.
What technique you can use? What are the maneuver or what you can use? What you can do to
Insert.
to insert the nasogastric tube?
I'm not that sure. Not so sure. Are there any
Actually, kan,
maneuvers?
okay, you can ask the child to actually drink. Bagi dia sip of water. And then while inserting the rice tube, you boleh suruh dia minum.
Oh, is that so that the it doesn't enter the trachea?
Yes.
Is that okay?
Because it will close the glottis and then dia akan because water akan masuk esophagus kan. So dia akan open up the esophagus. So water will get into the tube will get into the esophagus.
Okay.
Okay.
Thank you.
Okay. So
Alright.
next.
Bismillahirrahmanirrahim. Assalamualaikum. Can you see my slide?
Yes.
Okay. So I will proceed with lumbar puncture. Sekejap. So lumbar puncture, or we also call it spinal tap, is a procedure in which we insert a spinal needle into the subarachnoid space and then we take a sample of the cerebrospinal fluid. Okay, so indications to do lumbar puncture. We do it for to check for suspected CNS infections such as meningitis. This remain the most common emergency indication to do lumbar puncture. And suspected subarachnoid hemorrhage, in which if we do CT scan, it produces a negative result, so we need to do lumbar puncture. And then for to help in diagnosis of neurologic conditions such as Guillain-Barré syndrome and also multiple sclerosis. And also we do it in selected patients to investigate metabolic disorders, and also to administer medications such as intrathecal chemotherapy for cancer patients. Okay, for contraindication in lumbar puncture, we cannot do it in patient with increased ICP. So we should look at the sign and symptom of increased ICP, intracranial pressure, such as bradycardia with increased hypertension, and also papillary edema. So in this kind of patient, we should do CT scan or MRI brain first to check if there's any cerebral edema definition that could cause the increase in ICP. And then it's also contraindicated to do in respiratory distress patient because they may become hypoxemic and also apneic, especially if we put them in lateral recumbent position during the LP. Also, it's contraindicated in bleeding tendency patient. If the platelet count is less than 50,000 and also in prolonged PT or APTT, because this will increase the risk to get hematoma. And also in skin infect, is also contraindicated if there's any skin infection over the puncture site, because this can induce the infection into the subarachnoid space. It is also contraindicated in hemodynamic instability. So we need to stabilize the patient first before doing the LP. For complication, the first one is headache or back pain following the procedure. Headache is the probable etiology is because of the continued leakage of the CSF, and back pain usually resolve within a few days. Also, there may be several herniation may occur if the LP is done in increased ICP patient. Also, there will be hematoma. This occur in patient that when we do not correct the breathing disorders first. So also infection also could occur because of the induced infection from the skin infection over the puncture site. Also, when the stride technique is not, we do not use proper stride technique to do the LP. And lastly, the epidermal tumor, but this is a rare and late complication of the LP. Okay, so for lumbar puncture procedure, we need to evaluate the patient. If we need to identify if there's any condition that contraindicated to do the LP in the patient, and we should give the patient patient counselling, give them a clear explanation of the why we want to do the LP to them, the details of the procedure, what will happen, the complication, and also get written consent. And we must prepare all the equipment we need before that, such as sterile sites, sterile bottles, and also spinal needle with the stylet. And then we sedate the patient and apply local anesthetic. We use lidocaine 30 to 40 minutes before the procedure so that the anesthetic could take effect. And so for positioning, we could do lateral recumbent or sitting position. I provide the picture there. And then we need to identify the puncture site, which is in PH protocol. We use L3 to L4. So first we need to locate the posterior superior iliac crest first and draw the imaginary line. So the intersection of this imaginary line, the imaginary line and also the spine, is approximately at the L4. So by this we could find the space between the L3 and L4. And then we need to clean the skin at the puncture site with the chlorhexidine and place dry drapes underneath the patient and over the patient with a hole and we puncture the skin using the spinal needle gently at the mark point pointing to the umbilicus and at once slowly very slow. So when we advance the needles slowly, you will feel a sudden give feel or like a pop because there's a change of resistance when you penetrate the dura and enter the subaranate space. And then remove the stylet and look out for the CSF flowing out. So and then we measure the opening pressure by connecting the needle with the manometer. Also, and then we collect the CSF into the designated tubes or bottle. Usually, we use 4 bottles and about approximately 1 ml per tubes. And then, after collecting the CSF, we withdraw the needle and spray with the outside, cover with gauze and bandage, and ensure the child lies supine after the procedure, and continue monitoring till he recover from the sedation. I forgot to move the picture. Okay, that's all for me. Any questions?
Any questions? LP. What's your for LP? Okay lah. So in pediatric kan, what antiseptic do you use?
It's not chlorhexidine. I'm not sure. Maybe that what I need that chlorhexidine or we use povidone iodine solution.
Very good. What else? Anything? Any other solution that you're familiar with?
I'm not sure about.
Okay, that's the two most common lah. But sometimes we use alcohol. We use betadine. What else? Octanisan. There's a lot lah. But remember, we are moving away from using povidone iodine because of the risk of iodine toxicity lah, that will affect the thyroid hormone. But you need to know lah the type of antiseptic, and it's good to know the concentration, the diluent. Is it dilute in aqueous, in water, or is it dilute in alcohol? Okay, because it's quite important. Otherwise, okay, good. Okay. Just a quick a recap on physio or an anatomy. So, okay, where do you puncture again? Where do you puncture for LP?
Between L3 to L4 or L4 to L5.
Why?
At the level of cauda equina.
Okay, so you have to puncture below. Below what?
Conus medullaris.
Okay, below conus medullaris and below conus medullaris is cauda equina. After cauda equina is
filum terminalis.
The filum terminalis. So good. So that's why you have to puncture lah dekat cauda equina. So ada any other questions? Ada presentation ke?
Ada satu lagi.
Okay, proceed.
Okay, Bismillahirrahmanirrahim. Okay, can you see my slide? Okay. Today I will present the topic of height, weight, and of Occipital Frontal Circumference by me Khairul binti Muhammad. Okay. So generally in pediatric, for infant and toddlers for 2 years or younger, the essential growth measurement are length, weight, head circumference, and also weight to length. Meanwhile, for the children 3 years old or above, the essential growth measurement are height, weight, and also the body mass index BMI. So for the height, for the infant and toddlers, 2 years old or younger, we measure the length. So we need two people to assist. One to position the child, and another one to measure the length. And we put the child in the supine position on the measuring board like this. Meanwhile, for the children 2 years old and above, we measure the height by using the stadiometer. This is a stadiometer without the shoes. And we take the mean of the three measurements to get the greatest accuracy. And next we move to the weight. So for the weight for the infant or toddlers, 2 years old or younger, we using the calibrated weighing scales. At this, the what we call the infant need to measure the weight without any clothes or maybe the diapers. And for the children above 2 years old, we're using the standing weighing scale without the shoes and also the minimal clothing. And from this, with the height just now, we can calculate the BMI. So for the occipital frontal circumference, it is measured in children up to 3 years old. As this time, it is the greatest brain growth. And we measure it by using the flexible tape measure. And how we measure? We start from the frontal. We take the maximum diameter from the frontal through the supraorbital ridge until the occiput part. And the occipital frontal circumference, it need to be done in the older children with the abnormal height and weight. And for the abnormal head circumference, it is classified into macrocephaly, where the value is greater than 2 standard deviation above the mean, or microcephaly, where the value is lesser than 2 standard deviation below the mean. And this measurement can be affected with the thick hair or cranial bone deformation or hyperostosis. Hyperostosis is the excessive growth of the bone. So this is the picture of the micro and macrocephaly, and this is the front, yeah, the skull. So I will touch a little bit about the growth chart. So growth chart is a series of percentile curves that illustrates the distribution of selected body measurements. For example, we have the length for each chart and weight for each chart. So you can see the figure below. So the blue chart is for the boys and the pink chart for the girls. And how do we plot? So first we choose the relevant chart, whether we want uh, to choose the weight chart or the length chart. And then we find the age at the x-axis and the measurement at the y-axis. So from that, we plot by drawing a small dot. And then I touch about the BMI. So BMI, it is being calculated in the children's 2 years old and above. And how to calculate? We use the formula by BMI equal to the weight over the height square. And then we plot on the BMI reference chart. So if the value is less than 5th percentile, it is categorized as the underweight. If the value is more than 85 percentile, it is categorized as the overweight. And if the value is more than 95 percentile, it is categorized as the obese. I think that's all from me. Thank you.
Okay, good. Okay, that's very good. So BMI, after what age do we monitor BMI?
From what I read, it is 3 years old.
3 years and above, kan?
Yes.
So baby kita tak monitor BMI, remember baby we don't monitor BMI. And then we've got two charts. We've got the WHO and also the CDC chart. So WHO, the one that you've seen, is for less than 2 years, and the CDC is after 2 years. Okay. So if you got a child who came to you with height for age less than at lower than 3rd percentile. So what is your diagnosis? Okay, this is a 1-year-old baby with height for age less than 3rd percentile or less than 2 standard deviation below mean.
I forget the English name, but I think in the Malay it is bantut.
Ya ke stunted? Stunted lah, English name is stunted lah.
Stanford.
Is it really stunted?
Stanford.
Okay, true Okay, kalau dia height below age, untuk baby yang less than 5 years old, kan, baby untuk children less than 5 years old, if the growth chart height for age is less than 2 standard deviation from mean, so we diagnose it as stunted. Okay. Tapi if you got the same graph, but this child is 7 years old, so what is your diagnosis? You've got a 7 years old with a chart height for age less than 2 standard deviation of mean. Apa diagnosis you?
Bantu lah kan?
No.
No.
Stunted is a diagnosis for young children less than 5 years old.
Oh.
Kalau above 5, you don't call it stunted. You call it short stature. Lain tau, short stature and stunted lain. Stunted is bantut. Short stature is pendek.
Oh, okay.
Okay, what's the difference between short stature and pendek?
Short stature pendek, Stanford bantut.
Siapa tahu ni, I bagi dia RM5. Tapi lepas you datang sini lah. Kalau you ingat lah, I most likely akan lupa. Tapi kalau you ingat, you boleh datang tunjuk kat I. Kalau you tak nak, then you halalkan je lah. So, what's the difference between stunted and short stature? Sorry, this is my favorite topic. Growth is my favorite topic. My most favorite topic. So, I will spend some time on this. So, what's the difference between stunted and short stature?
Short stature could be because of genetic, family traits.
Stunted. Stunted tak boleh genetik kan? Okay, Nadia, your homework is try to contact any of your 5th year senior. Okay, ask them, get from them their slide presentation on stunted and short stature. On short stature, get their slide presentation on short stature. Kan ask them to share lah. You bayar ke, you tak kisah lah, you buat macam ni kat dia orang. And I want you to look at the slides and get back to us, to your friend and to myself. Why children below 5 because stunted? Why children after 5 with the same growth chart? We call it short stature.
Okay.
Okay. So I want you to present back on interpretation of growth chart. Later you will, I think in 5th year you can, I think your 5th year present this for short stature topic. Tapi I think 3rd year should know already because this is not something yang medical. Dia macam basically you just plot and then you diagnose. So you minta slides daripada diorang to any of your seniors, slide on short stature, and then you just present different diagnosis of growth chart at different age.
Okay.
Just 3 slides cukup lah, 3-4 slides, you know. So you present next time.
Okay.
Okay. So your presentation kalau good, I bagi you 10 markah for your presentation. Kalau tak, then you dapat half of that lah. Okay, anyway, so next time, I nak minta one of you to arrange another session untuk kita for us to for siapa nama yang lelaki tadi?
Syafiq.
For Syafiq to represent the Venipuncher and also for Nadia to present the difference between stunted and also short stature.
Okay.
Just that lah. At least you can focus on that. That's more than good. So difference between short stature and stunted, and why? Why do we call them different? Dia sama macam, you know, GDD and also slow learner. You tahu kan GDD? Apa GDD? Global Developmental Delay, tahu? Okay, how do you diagnose global developmental delay?
Is it based on the developmental milestone?
Yalah, so macam ni nak kata someone to developmental delay, global developmental delay.
Kalau macam dia tak boleh jalan at 18 months, and then
They delay in at least 2 of the domains, Doctor.
Good. So global developmental delay, kalau dia ada delay in 2 or more domain kan. So how about slow learner? How do we diagnose slow learner? Ataupun learning disability. So learner sama lah dengan learning disability. So how do you diagnose learning disability? Okay, basically it's the same lah. It's the same thing. So GDD, slow learner, learning disability, these are the same thing. Cuma GDD is a diagnosis before preschool. So macam budak 2 tahun, 3 tahun yang ada delay in 2 or more domain kan, then we call it global developmental delay. But once they reach 5, 6 years old, when they are supposed to learn, they're supposed to go to school, then we call it slow learner ataupun learning disability. Faham tak? It's just the age yang beza kan diorang. Because it got implication in the management and also in the investigation and also in the treatment. Okay. Similar to stunted dengan short stature. So there's a clue lah. Nanti you baca and then you present to us. Okay, I rasa tu cukup. Any other questions?
Doctor, you said kita monitor BMI above 3 years and above. So kita monitor sampai umur dia berapa?
Sampai dia tua lah. Sebab sekarang orang tua pun kita monitor BMI.
Oh.
I mean, as long as dia still follow up under us, then we monitor lah. Once kita discharge to adult, then adult lah monitor. But BMI, semua orang kena monitor. Once you 3 years old, then use BMI. Remember, because obesity, we can use BMI to diagnose obesity. We can also use weight for age to diagnose obesity. There's also another chart yang kita guna weight for height. Weight for height. Height for weight. I think height for weight. Yes, height for weight. So these are growth chart. Growth chart is very unique now because it's not just like a simple chart because you use it to diagnose, and it's very, very important. Okay, you have to plot it correctly and to interpret it correctly. And that's like berpuluh-puluh growth chart. Okay, which is very interesting lah. Okay, ada soalan lain? If not, okay, today, ada soalan apa dia?
Tak. this is not a question, but I just want to tell you that we have a session on 19 February.
Session apa tu?
Session procedure presentation juga.
Banyak hari tu dah presentation kan? Banyak presentation.
Kita ada dua.
Hmm.
Our group have 2 sessions for procedure presentation with you today and also 19 February. So kalau yang
hari
macam
tu group lain
Syafiq, maybe this is the first session with you.
Oh ya, dah I confused lah. Okay, anyway, tak pula 19 tu ada berapa presentation?
So 19 tu there will be 5 more students present, and then include Syafiq and also Khairul Nadia tadi. So I want to ask you if you want to do separate session for Syafiq and Khairul Nadia, or
Yes, can we do like separate session? Maybe Taufik and Khairul Nadia and one more. So the next one will be only 4. Betul tak?
The next one will be 5.
Lah, so one of the presentation from the next one kita present sekali. So there'll be 3 and then 4.
Okay.
So I also panjang sangat lah. One hour is a bit too much of my concentration, and my attention span is very short. Okay, so okay lah, nanti you arrange. So we split the presentation to 2 session. So the next one will be 3 and then followed by 4. Okay.
Okay.
You decide lah bila masa and then just inform me.
Okay.
Okay, I think that's all lah. Okay, kita tambahkan perspektif orang. That's what to ask. Yes, welcome to Library.
Thank you, Doctor.
Thank you.
Thank you, Doctor.